Let's talk for a few minutes about the staphylococci. When we say the staphylococci, what we mean is species within the genus Staphylococcus. That's the clinical use of that term. There are really only two species of staphylococci that have much of anything to do with humans. Those are Staphylococcus aureus and Staphylococcus epidermidis. Staph aureus colonizes the nasal cavity at about a 20% rate. What that means is about 20% of your life, you'll be Staph aureus positive, so it's sort of a short-term resident flora, not quite transient, but not exactly lifelong resident. So if you look in a room of 100 people, chances are 20 of them are Staph aureus positive in the nasal cavity. Staph epidermidis, on the other hand, covers your skin for pretty much your entire life. About 90% or maybe more of the microbes on your skin, which are there at a concentration of about 1,000 cells per square centimeter after you shower. About 90% or more of those are Staphylococcus epidermidis. Aureus is a transient on the skin, presumably coming from the nasal cavity, and isn't going to stay there long. You take a shower and it's gone again. Epidermidis is typically not pathogenic. We call it an emerging opportunistic pathogen. Emerging means that it's just shown up on the scene. Either it's been a pathogen all along and we've only started realizing it, or something has changed, genetically most likely, maybe plasmid acquisition, that has made an increasing number of epidermidis strains potentially pathogenic. And opportunistic, as you know, means that it can be on your skin, not causing any harm, but the moment you get a cut, the moment there's a post-op infection, etc., epidermidis has an opportunity to cause an infection in you. We're seeing this primarily in the healthcare setting, not in the community yet. Staph aureus, on the other hand, is a greater likelihood of being pathogenic. So even when you're carrying it during those 20% periods that you're carrying it in your nasal passage, you do run the risk of a Staph aureus infection, both in the healthcare setting and more recently in the community setting. So we're seeing hospital-acquired HA Staph aureus and community-acquired CA Staph aureus. And then there are three other abbreviations I want you to be familiar with. You've all heard of MRSA, M-R-S-A, methicillin-resistant Staph aureus. Understand that what that implies is multi-drug resistant Staph aureus. It's not that, gee, we lost the one drug, methicillin, but the implication is that if methicillin's not working, there are also many other drugs that are not working. So with MRSA strains, we tend to have a shorter list of possibilities that we can use to treat it clinically. MSSA, MSSA, is methicillin sensitive. Those are the strains that still products, including methicillin, among others. And then VRSA, VRSA, vancomycin-resistant Staph aureus. Vancomycin is typically our go-to drug of last choice. So we only hit an infection with vancomycin when everything else is not working. So you get a MRSA strain that's not responding to, say, clindamycin or some other drug that many of the MRSA strains are still sensitive to, we may have to go to vancomycin. Vanc is only good against gram-positives, but unfortunately it has some toxic side effects to the host, in particular ototoxicity in the ears, nephrotoxicity, and liver toxicity as well. And those all have to be monitored carefully when someone is on vancomycin. So what are the staphylococcal diseases? Non-invasive staph diseases are the first category we're going to look at. These are food intoxication. That doesn't mean your food had a wild weekend in Tijuana. What it means is that staphylococci, primarily Staph aureus, okay, from here on out we're really talking about Staph aureus. Staph aureus got into the food and secreted an enterotoxin, a toxin that attacks the intestinal lining. Even if the food is properly cooked afterwards, sometimes that's not sufficient because many of the enterotoxins are actually heat stable and can handle the heat quite fine. Food intoxications usually hit very fast. You eat a sandwich, a taco salad, a potato salad, whatever, and something's not quite right. Usually within just a couple of hours there's vomiting. There's a very rapid onset, and that's worth looking at with your patients. How quickly after eating questionable food did vomiting particularly occur? The good news, though, is that there's typically rapid convalescence. So usually within 24 hours you're starting to feel like you've turned the corner and you're beginning to improve. Then there are the cutaneous staphylococcal diseases. These are often referred to as pyogenic staphylococcal infections. Pyo means pus, so these are pus-generating or pus-causing infections at the skin. 3 in particular. On the left, we've got scalded skin syndrome. You can see it looks like this young boy's face has been burned, but it hasn't. The desmosomes that are attaching the different sheets of epidermal layers to one another get disrupted, and the skin peels away in sheets like that. Interestingly, scalded skin syndrome is not particularly dangerous except for the potential for secondary infections, and it tends to heal without any scarring at all, roughly a week, week and a half. So it's as bad as it looks. It's a lot worse looking than it actually is. The middle one, a little girl with impetigo, group A streptococcus, that's Streptococcus pyogenes. We'll talk about that on the next video. Can also cause impetigo. Sometimes impetigo, especially if it's still in the early stages and maybe is just around the mouth, will look a lot like a cold sore, but cold sores tend to stay around the edges of the lip. And when you start seeing these types of sores, whether they're open, like you see on the cheeks of this little girl, or crusted over, like around her nose, those sores away from the lips, you should be thinking impetigo. Can be Staph aureus, Streptococcus pyogenes, or sometimes, if you're lucky, both. And then on the right, we've got folliculitis, which is just a term that describes the infection of hair follicles. And these are usually, they are pimples, pustules, boils, and styes. So you see boils in the back of this man's neck and the thick skin, and you see a stye on the person's eye down below. These are infections of the hair follicle. They tend to be highly localized and treatable. And then finally, we've got the systemic staphylococcal infections. This is when an invasive form of staph either invades tissue or finds its way into the bloodstream. The first is toxic shock syndrome. There are a few different species that can cause toxic shock syndrome. Shock is not, clinically, doesn't mean the same thing as how we use it in our culture. We might say, oh, he was in shock, or he was in a car accident and was sort of dazed and confused. I think he's in shock. That's more of an emotional response. Shock clinically means that we're not getting enough oxygen to organs due to low blood flow, low blood pressure, and those organs are actually beginning to fail. So shock is a very, very dangerous situation. Toxic shock is simply when that low oxygen flow, low blood flow, and ultimately organ failure is caused by bacterial toxins, and in this case it's staphylococcal toxins. There's something we call TSS1, toxic shock syndrome toxin 1, that is very commonly associated with staph infections. Bacteremia, live bacteria in the bloodstream, endocarditis, bacterial infection of the heart, pneumonia, bacterial infection of the lungs. Staph aureus is not really commonly found in the lungs, but when it is there, it can be pretty difficult to treat. And then osteomyelitis, which is a bone infection. We're going to talk through some different virulence determinants now for Staph aureus. Some of these are extremely common, almost universal in strains of Staphylococcus aureus, and others, fortunately, are very rare. Protein A is essentially universal in Staph aureus, and it's pretty cool. When an antibody tries to bind to the surface of Staph aureus, protein A flips it upside down so that the white blood cells don't know what they're looking at. Coagulase causes blood to clot around the inoculum, allowing the staph strain a little bit of time to grow and establish itself before immune factors like complement and white blood cells are able to get to the site of the infection. There's a capsule, and in the world of staphylococci, we call it the slime layer. It inhibits phagocyte chemotaxis, so phagocytes have a hard time locating staphylococcus cells, Staph aureus cells, and chemotaxing towards them. When they do find them, they have a hard time attaching because they're slippery, and it allows the staph to form biofilms, and those biofilms can be particularly problematic, as we've talked about. When a Staph aureus cell is in fact consumed by a phagocytic white blood cell, that phagosome body still needs to fuse with a lysosome inside the white blood cell. The phagosome alone is not going to kill the bacteria. When it fuses and the contents of the lysosome pour out into the phagosome, we call that a phagolysosome. Among many other things that are used to attack the bacteria, hydrogen peroxide is produced along with some highly reactive oxygen species. Catalase is an enzyme. You and I have a lot of catalase, in fact, in our tissues. that can take H2O2, hydrogen peroxide, and convert it to water and oxygen gas. That's why when you put some peroxide on a cut or an open wound, it fizzes and bubbles. That's your tissue protecting you from the H2O2. Staphylococcal pigment's kind of cool. This is where Staph aureus gets its species name. Right? Aureus comes from the Latin for gold. Think of the periodic table and the AU. Staphylococcal pigment is a yellowish-orangish pigment that we see in Staph aureus colonies. And it will actually absorb the high energy of some of these oxygen-free radicals that are being used. And so basically what we've got is a lot of ways to avoid being phagocytosed. It's amazing that we're able to clear any staph infections at all. Now, staphylococci does the opposite of coagulase. A staph colony, if you will, that's growing locally in a person can't stay there forever. It's got to break free and try to spread. And staphylococci actually degrades clots and increases the spread. And so using the two alternately, coagulase and staphylococci, you could envision a strategy for Staph aureus to start locally, hiding from the immune system, break free and make a run for it, and then the individual cells, as they spread out, stopping with their kinase production again and switching back over to coagulase to protect themselves yet again. Hyaluronidase is pretty rare. It degrades some of the carbohydrates called hyaluronic acid in the extracellular matrix and allows for highly invasiveness, a high degree of invasiveness. And then leukocidin is a cytolytic toxin. It's a toxin that busts apart cells. It would bust apart red blood cells, white blood cells, skin cells, and it's responsible for forming skin lesions. It's also responsible for helping some of these Staph aureus cells to break free from phagocytes when the phagocytes engulf them by essentially blowing them up from the inside out. Two more, beta-lactamases. You guys know what beta-lactam antibiotics are. Beta-lactamases are the most common way that bacteria protect themselves from the action of the beta-lactam antibiotics. Roughly 90% of all Staph aureus strains in the US are believed to be beta-lactamase positive. That severely limits our options for antibiotic therapy. And then clumping factor, not entirely clear on how clumping factor works, but it binds to fibrin and fibrinogen and allows for potentially for biofilm formation. Now, we've done a little bit with blood agar in the lab. Alpha hemolysis is a cytolytic toxin that only partially breaks open the red blood cells that are in this agar, and so you see this greenish alpha on the left. Beta hemolysis completely busts them open and degrades the hemoglobin inside, and so everything turns clear around the colony in this case. And then gamma hemolysis is kind of silly. It actually means non-hemolytic. I don't know why they don't just call it non-hemolytic. Staph aureus is typically beta hemolytic on blood agar, and Staph epidermidis is rarely ever hemolytic. Let's look at a couple more toxins. Exfoliative toxin is involved in disrupting those desmosomes that we talked about and leads to scalded skin syndrome. Only about 5% of Staph aureus strains are carrying around this exfoliative toxin with them. And little kids and little old ladies are at the greatest risk. And again, no scarring. 7 to 10 days tends to heal up on its own. Subsequent infections are the biggest concern here. Enterotoxins, entero referring to the enteric system or the intestine system, are toxins that give you diarrhea or vomiting. They attack the lining of the intestinal tract. They cause gastroenteritis, a much better term than the stomach flu that a lot of people like to call it. Diarrhea, vomiting, cramps, fever, these tend to be heat stable, so if they're in the food, if the food was mishandled prior to cooking, cooking is not going to save you. This causes an intoxication rather than a live culture that's growing. We would call that a foodborne infection rather than a food intoxication. Here's our TSS toxin that we talked about. This is what's called a superantigen, causes a hyperimmune response, massive release from your helper T cells of cytokines, signaling molecules, far greater than your body can actually handle. And here's where shock comes in. Lowers blood pressure, limits oxygen delivery to organs, that is what we call shock, and ultimately can lead to organ failure. And toxic shock syndrome has about a 5% mortality. Both Staph aureus and strep pyogenes are common causes of toxic shock syndrome. You can see the effects here of the alpha hemolytic cytotoxins destroying this person's skin in the process of TSS. All right, that's all I've got for you for Staphylococcus. Go through this several times. Read what I assigned to you in the textbook so that you're ready to go. And let me know if you have any questions.